My name is Mark Siegler. I'm delighted to welcome you to today's lecture sponsored by the Bucksbaum Institute. The Bucksbaum Institute was created about 4 years ago with a gift from the Matthew and Carolyn Bucksbaum Family Foundation. And its mission is shown on this first slide: to improve patient care, to strengthen the doctor-patient relationship, to enhance communication and decision-making between patients and physicians. It's now my pleasure to introduce you to today's speaker. We're delighted to welcome Dr. Lisa Cooper to the university. Dr. Cooper is the James Fries Professor of Medicine at Johns Hopkins University, where she holds joint appointments in the medical school as well as the Bloomberg School of Public Health and the Johns Hopkins School of Nursing. Dr. Cooper is a general internist, social epidemiologist, and health services researcher, the author of more than 170 articles and book chapters. Dr. Cooper at Hopkins directs the Center to Eliminate Cardiovascular Disparities. This is a center where she and her multidisciplinary team work with a broad group of stakeholders to implement rigorous clinical trials, identifying effective and patient-centered solutions to alleviate disparities in health among ethnic minorities and the poor. Dr. Cooper has received many awards for her pioneering work, including a prestigious MacArthur Genius Fellowship, elected membership in the American Society for Clinical Investigation and the American Association of Physicians, the Delta Omega Public Health Honor Society, and is a member of the National Academy of Medicine. Dr. Cooper also has received the Herbert Nickens Award from the American Association of Medical Colleges for outstanding contributions to promoting social justice in medical education and healthcare equity. Today, Dr. Cooper will speak to us on the topic, A Global Perspective on Health Equity, One Physician's Journey Off the Beaten Path. Please join me in welcoming Dr. Lisa Cooper.
Okay, can everyone hear me? Good. Well, thank you for inviting me, Dr. Siegler, and thank you to the Bucksbaum Institute as well as to the Bauman Society. It's a pleasure to be with you this afternoon to talk with you about my journey off the beaten path. So just to give you an overview of what I'd like to talk with you about today is first, I would like to tell you a little bit about health disparities and how we might move from health disparities to health equity. Share with you the relationship-centered principles that have guided me on my journey, and then some lessons that I've learned along the way. So health disparities, so I'm having a technical problem, so I'm going to just ignore what I'm seeing on the screen here. The notes are not matching up with what's on the slide, so. So first of all, health disparities are preventable differences in the burden of disease or injury or violence or opportunities to be healthy that are experienced by people from socially disadvantaged populations. And I'm sure many of you have heard a lot about health disparities over recent years as there's been much more national attention focused on it. To address health disparities, we have to first understand how they originate. And they originate from complex factors that interact with one another. So there are social conditions in society that determine, for example, where we live. There are economic policies that get decided by decision makers. There are institutional factors like where we work, where we go to school, what kinds of opportunities we get afforded by those things that impact on our ability to stay healthy. Health system factors play a major role. Those of us that are clinicians in the audience know that we see a lot of health inequities in people from different backgrounds, and that we have an opportunity there to make a difference. There can also be physical environment, so people may live in crime-ridden neighborhoods, social relationships, as well as risk behaviors. Now, a lot of people think that health disparities are because of choices that people make related to risk behaviors, but you can imagine that if you live in a neighborhood where you cannot get to a place to exercise, that can shape whether or not you make a decision to be physically active or not. So it's much more than just individual behaviors. So I wanted to show you a little bit, this is a slide of the Washington, D.C. Metro. And we've seen pictures like this recently that just kind of illustrate how much it matters where we live. So if you just look at the D.C. Metro map, you can see that from the center of the city, the life expectancy in Washington, D.C. average life expectancy is 72 years. And just a few miles away, if you take the red line, for example, to Montgomery County, there's about a 30-mile range, and there's a 9-year gap, okay, in life expectancy. So if you just took the metro, the red line out, you have almost a 9 years difference in how long you're going to live. And that can be seen for other areas around Washington, D.C. as well. Now, for where I work and see patients, I showed this slide last night to the Bucksbaum faculty. In just 5 miles, there's a world of difference. There's a neighborhood called Roland Park that is about 5 miles away from where I work at Johns Hopkins, and it has a relatively high average income, very low unemployment rates, life expectancy of 83 years, and a very low homicide rate, only 4.1 per 10,000. Whereas in Madison East End, where Johns Hopkins is located and where I see patients at the East Baltimore Medical Center, the average income is about a third of that. Unemployment is about 3 or 4 times as high. There's a 20-year gap in life expectancy across those 5 miles. And the homicide rate is 10 times higher. So in the US, this is just in the United States, there are a lot of factors that contribute to our differences in life expectancy, and where we live is the greatest one, but things like our income and our education and our race actually contribute substantially to those differences. So we're just talking about life expectancy. And now, so what I'm going to show you is that, disparities are actually pervasive. So it's not just only about mortality, but it's about getting sick from a variety of different conditions. So they affect not just mortality, but also quality of life, sickness, and costs. Disparities are very costly to our society. And in some talks that I do, I actually show that over a 3-year period, we could actually save $1 trillion if we eliminated disparities in health. So what are some of these disparities? These are some of the common ones. If on this slide, for every person shown in blue is a white American, and then the people shown in red are a minority group. There are more people of color affected by these conditions than whites, so these are race disparities. And you can see here that for every one person with diabetes, one white person with diabetes, there are 3.5 times as many, 2 times as many African Americans, 1.5 times as many Hispanics, and a little over 2 times as many Native Americans affected by diabetes. So that's just one example. You can see infant mortality is another example, and look at HIV/AIDS. That's unbelievable. This is also showing stroke. This is cervical cancer, disproportionately affecting Vietnamese Americans, and then prostate cancer. So health disparities are a big problem, and we all know that. But where we're aiming for is health equity. And I say that because I think it's really important that we reframe this problem in terms of where we're going and in terms of what strengths we have and what resilience we have in order to address these issues. So health equity, we have to remember, is where we're where we're looking and where we're aiming. That's the vision we have, that when every person in our society has the opportunity to attain his or her full health potential. So no one is disadvantaged from achieving this potential because of socially determined circumstances. And a lot of people think that to get rid of disparities, that basically you need to just give everyone the same thing. But I want to make this really, if you don't remember anything about my talk other than this, remember this, that this is a disparity, right? These kids are watching a baseball game. You give them all the same thing. This is equality. And they still can't all see the game, right? But this is equity. Achieving equity requires different resources for different people and different groups, and that's what we have to keep in mind. So how do we do that? There's so many different roads that can lead to impact on health equity. So when I was, contemplating what I would do when I completed my training and became an adult, a lot of these things went through my mind. I knew I wanted to be in health professions, but I didn't know whether I wanted to do clinical practice, education, whether I wanted to do public health practice, healthcare administration, research, policy, or whether I wanted to be really just out in the community and be an advocate. So if you're considering a path in this area, there are lots of different ways to go. What I'd like to tell you a little bit more about now is my journey on this path and how relationships have actually helped to guide that path. So why relationships? Well, relationships, I wanted to just think about what is a relationship. So a relationship is a state of being connected through mutual interest or involvement. And as you can see, if you're going to try to address health equity, there are lots of different people that you need to draw upon for that. So, and why do I care about that? As a health professional, we know that relationships provide the context for healthcare. When people come in for healthcare in order to make an appointment, to have a diagnosis made, to be referred for treatment, to get the treatment, they have to interact with other people. So relationships are kind of the center pin point of healthcare. And a few years ago, my colleagues and I had the opportunity to work with a group to establish a network of researchers called the Relationship-Centered Care Network. And through that network, we came together and we decided that we were going to try to define better what relationship-centered care was and what were the various components of that. And what we came up with was that relationship-centered care is care in which all participants appreciate the importance of their relationships with each other. So it started out with the doctor-patient relationship, but one of the other things we realized quickly in thinking about relationship-centered care was that there are a lot of other relationships that matter as well. So there are relationships with other health professionals. There's a relationship of the clinician to himself or herself and to one another, and then also with community. So I'm using this framework, this relationship-centered care framework, as I tell you about my journey. So I want to start first with the relationship of the clinician to self. So as you think about this, think about what your values are, and whether you're living in alignment with your values, and what experiences make you who you are. So that's what I'm going to talk to you about today. So I want to start out with my core values. So my relationship to myself begins with a regular examination of these core values. And when I do this, I'm able to plan and I can pursue my interests and my highest priorities and live in alignment with what's important to me. So I'm showing you these so that you can see how I developed my commitment to social responsibility and service. And then the value that I placed on relationships and having a holistic view of health. So how did I develop these core values? I was born in Liberia, West Africa, and this is a country that was founded in the early 1800s by freed slaves and free blacks who left America and went back to Africa in search of freedom and a better life. And unfortunately, Liberia has been in the news a lot in the past year because of the devastating impact of the Ebola outbreak there. But growing up in Liberia, I was definitely aware of how good my health and quality of life were. I went to an international school with children whose parents were diplomats, but many of the children I saw on the streets in Liberia were not as fortunate. So these are some photos of Liberian children. And what I would say to you is these are some of the faces of health disparities. They're very reminiscent for me of scenes of my childhood. And many Liberian children now have been orphaned because of the civil war that took place there, as well as the current Ebola outbreak. So you can see they're smiling. And so you can, in the face of immense suffering and deprivation, you can still see the strength of the human spirit. And, I saw these children every day, but my life was very different. These are my parents, Izetta Roberts Cooper and Henry Nehemiah Cooper. And they taught me the importance of professionalism and service to others. So my father was a surgeon, and my mother worked as a librarian at the University of Liberia. And when they completed their education together, they returned home to Liberia. They were educated in the US, and they went home and they established the Cooper Clinic, which is a small hospital that provided primary care and specialty services to the community. And my parents were also actively involved in the community. They worked on things like my mother was on the leprosy control board, for example, and my dad was a Rotarian, and they focused a lot on improving adult literacy. So I learned a lot about service and giving back to the community through them. My parents also taught my brother and my sister and me that life was about how you use the gifts and talents you have to give back to others and to improve the lives of others. So watching my parents, we learned the importance of service. And my parents also taught us to prioritize relationships. We had a very large extended family, and we still have that now. In fact, my husband's always wondering when he's going to meet the last cousin that I have. So, but our family was very important to us. We have a very, very close-knit family, and lots of aunts, uncles, and cousins, and it was always emphasized that it was important to maintain and strengthen those relationships. So that was a strong part of my family background. I came to the US when I was 17, and I came here basically at that time to go to college, but also to escape from the violent conditions that were going on in Liberia at the time. There was a coup in Liberia in my last year in high school. And then after I graduated from Emory College and went to the University of North Carolina for medical school, I did my residency at University of Maryland Hospital in Baltimore. And during my residency, one of the things I realized was that actually people in Baltimore City were experiencing things that were not that different from the people in Liberia, on the streets in Liberia. They had very similar financial struggles, the exposure to violence. They had problems communicating with health professionals. They had trouble finding meaningful work. So there were a lot of similar conditions, and one of the things I realized was that I had a limited ability to make a difference in those people's lives by just being a clinician. I could still help people a lot, but there were so many other things going on outside of healthcare that I could do to help me actually address some of these problems. So I decided to go to Johns Hopkins and study public health so that I could get involved with addressing health on a broader level. So I went to the Bloomberg School of Public Health. So that took me to the next place on my journey, which was doctor-patient relationships. After I finished my training, I wanted to go into clinical practice and then also to pursue a career in public health research. So some of the things I thought about early on were how could I become an excellent physician, right? An excellent clinician. And then I was also really interested, because of my experiences with those patients during residency, one of the things I realized is that a lot of problems were related to communication breakdowns and people not basically understanding or relating to each other well. So I got interested in why whether better clinical relationships could actually improve health outcomes, and what role did improving those relationships play in trying to enhance health equity. So this is me at the East Baltimore Medical Center, and this is where I practice right now, and I precept medical residents. And that is in the Madison East End neighborhood that I just told you about, right there where there's that 20-year gap in life expectancy. So what I did was, this is my clinical practice, but as I practiced, a lot of questions came to mind. And one of the first studies I did was a focus group with patients. I was interested in understanding from African American patients who were getting help from primary care doctors about what attitudes and behaviors they thought their doctors should have in order to help improve their outcomes. And I think this quote, I'm showing this quote from one of the focus groups, really shows the importance of a good patient-physician relationship. And this is an African-American woman with depression who said that the doctor I have now is great, he's nice and calm, and he asks a lot of questions. He is very, very sharp. I think whatever this guy tells me, for the most part, if it sounds sensible, I'll give it a try. So I thought that really told it all about the importance of the relationship. And in fact, that was the #1 factor that came up in my research in trying to understand more about what patients wanted, is having a trustworthy physician. So this led me to the next study. So one of the things I did was to try to actually understand more about which outcomes were improved by doctor-patient relationships. And this just shows you that this is from a number of studies, not just mine, that better communication actually improves all kinds of outcomes. It improves patient knowledge and recall of information, and I'm probably preaching to the choir here. It improves patient adherence, as well as satisfaction, as well as clinical outcomes. So this is, these are reviews of several studies that have shown this. There hadn't been as much work when I got started looking at how communication differed in the visits of minorities and whites. So some of the studies I did early on showed that African Americans had lower levels of trust in physicians, and that they also experienced less participatory communication with their physicians. There was more technical and biomedical conversation in those visits with African American patients, and there was less rapport building and psychosocial communication. So just meaning that they'd spent less time talking about things like work or home or personal concerns that weren't strictly medical. So I didn't think doctors were doing this intentionally. I really wanted to find out whether there were some other attitudes driving this. So I wanted to actually get into exploring more about physician attitudes. The other interesting thing that I found in doing this work was that when doctors and patients shared racial and ethnic background, that the visits were actually longer, and that the physician and patient talked more slowly, and that they both sounded happier. And this is based on listening to audio recordings and having objective raters to rate the communication and to quantify the discussion. So not believing that doctors are actually doing this intentionally really drove me to understand more about what attitudes could be affecting this. So we moved on to study implicit racial bias, and we used a test called the implicit association test. How many people here have done it? Okay, lots of people. So we used the race implicit association test, or IAT, and you're supposed to match good words and bad words to people belonging to different racial or social groups. So there are lots of different IATs, not just race. And so what we did was we gave that test to doctors, and we found that just like the rest of the US population, about 70% of primary care doctors had an implicit bias favoring whites over blacks. And then what we did was we actually measured the communication in those visits between the doctors and their patients, about 10 patients per doctor, so about 250 patients overall. And what we found is that the higher the implicit racial bias score, the poorer the communication was in the visits with African American patients, but not with white patients. So we found that implicit racial bias was associated with poor communication. And when I'm talking about poor communication, what I'm talking about is things like dominating the conversation, talking more than the patient was talking, things like really basically sounding more rushed and more hurried and less interested. Again, by these independent raters who actually didn't know what we were studying. The other thing that we found is that when doctors had implicit racial bias, that their African American patients also rated them poorly on respect and on liking and on satisfaction. But the same was not true for their white patients. So implicit racial bias had more of an impact on African American patients than on white patients in these studies. So that led us, I know this sounds like really depressing. So, I really wanted to get to not just like figuring out the problem, but also because we're learning more about what the mechanism is trying to see if we could come up with interventions to overcome it. So one of the interventions we tested early on was an intervention where we actually trained doctors to be more patient-centered, to not talk as much, to listen more, and to ask more open-ended questions so that patients would disclose more things about their personal lives. And so we did that with a training program that they took on a CD-ROM. And that CD-ROM actually gave them feedback. What we did was we got them to agree to be videotaped, seeing a standardized patient, and then we gave them feedback on how they did in that interview, whether they engaged in the right kind of like question asking and whether they allowed the patient to be involved in decisions as much as they should have. So we did that, and then at the same time, we also, the study was a randomized trial, so half of the physicians got that training and half of them didn't. And then among the physicians who were trained, half of their patients actually also got coached by a community health worker, and then half of them didn't. And we did that the same in the other arm. So we had 4 arms. We had the group where the patient got coached and the doctor got trained, the group where the doctor got trained but the patient didn't, the group where the patient got training but not the doctor, and then the one where neither got. And so the coaching by the community health worker was like to help the patient prepare for the visit, to ask questions, to clearly state what their opinions were and their concerns, and that went on for over a year. And what we found is that patients who were coached and whose doctors got the training showed greater improvements in the way they exchanged their information, like how much information they shared, the decision-making on the part of the patient, and then they also showed greater improvements in their blood pressure. So, this shows that you can actually change physician behaviors. I don't know how easy it is to change attitudes. We're still working on that, but one thing that's believed in the social and behavioral literature is that actually changing behaviors can lead to changed attitudes over time. So sometimes if it's harder to change an attitude, you can change a behavior, and when people begin to behave in a certain way, they then begin to understand the attitudes that could have been driving their behaviors previously. So this is another intervention. I'm not going to spend as much time on it. Another intervention where we engaged in communication skills training for physicians in this patient-centered group. And in the standard group, the physicians didn't get any training in communication skills. This intervention was delivered to the patients by social workers, and one program was basically a standard disease-focused intervention for depression, whereas the other one was focused more on what the patient's attitudes and beliefs were, the patient's preferences for treatment, and on improving the relationship with the clinician. And we found that patients in both groups showed similar improvements in depression, but the patients who went through the standard arm actually ended up going in for treatment more, and the patients who got the patient-centered group actually rated their care better. Even though they didn't improve the number of visits they had, they actually were more pleased with their visits, and they got better at the same rate. So what else? What else should we be talking about? As I went through this whole journey and pursued all of my interests in the doctor-patient relationship, one thing I realized was that those relationships don't take place in a vacuum. So a lot of what influences how we work on a day-to-day basis is how we interact with others around us. So I'm going to tell you a little bit more about how doctor-colleague relationships have informed my journey. So one thing that I want to focus on is mentors, because I think that's been really fundamental to me being successful. I want to talk about how we can actually mentor others and what we may learn from mentoring others. I want to talk about collaboration and teamwork and how that's helped me, and then also just leave you with a few thoughts about how you might enhance your professional relationships. So these are my mentors. Many of them I've been incredibly blessed with excellent mentors and role models. And you can see from the slide that they come from diverse racial and ethnic groups. They're men and women. They come from various cultural and religious backgrounds. They also come from diverse scientific disciplines and clinical specialties. And I needed all of those diverse values to teach me what I needed to know about science, about medicine, about relationships, and about life. So a lot of these people have helped me become who I am today. And I also learned a lot about the importance of how to demonstrate my values and behaviors by example from watching these folks. And you may recognize some of them. Some people in the room may recognize some of them. But I've also learned a lot from my mentees. So these are a lot of people I've mentored. I think you can see one familiar face on here. I'm so grateful for the honor of being able to work with each one of these people. Each one of them has taught me how to be a better listener and a stronger advocate. I've learned about the importance of caring for them, not just as scientists or researchers or future physicians, but also caring for them as individuals and respecting them, valuing their unique abilities and contributions. And even if they don't always agree with me, because they don't always agree with me. But I've also made a lot of sacrifices to be able to spend time with them on a regular basis, and that has helped me grow. And part of my role with them is to be a nurturer and an encourager, but also to actually challenge them and hold them accountable as well. So I feel like this has been a very important part of my journey. And then these are colleagues of mine, and I just want to say that a few years ago I had the opportunity to establish a center, a transdisciplinary research center that addresses cardiovascular health disparities. I talked a lot about this last night, and we've just completed 3 studies that deal with improving hypertension control in underserved communities in Baltimore. And again, I would not be able to do this work without all of these people. I've got a fantastic hypertension expert here, biostatistician. This is the chair of our community advisory board. That's me, and then my colleague, Ebony Bulwer and Sharita Golden, other leaders of the studies and of the training pieces. So what did we find? We had 3 studies that we did, and I talked about them last night, that focused on improving blood pressure control, and 2 of them actually focused a lot on improving relationships. So this one had a provider communication skills training piece where we focused on improving the patient-centered skills of the providers. This one focused on community health worker patient interactions, and also focused on improving patient and family decision-making with their doctors. And this one had a health coach, and I guess you could say in a lot of ways, people wouldn't have bothered to eat healthy or follow the plan in this study if the health coach hadn't been someone who really engaged with them and really understood a lot about what they were facing. So I guess you could argue that with all of these interventions, there was some degree of relationship building and social networks that was responsible for achieving the goal that we set out to achieve. So, and then my latest project is another trial that is going to look at a new model of care that involves a collaborative care team that includes a community health worker and compares that to a standard quality improvement strategy in primary care settings. And it's focused very heavily, again, on the patient and the patient-physician relationship and the patient relationship with all the members of the healthcare team, and getting patients more actively involved in determining what the care process should be. So in fact, some of the most important outcomes are going to be patient-related outcomes like activation, self-management behaviors, attainment of goals, and experiences of care. So I'm trying to see how much time I have. I think I'm still doing okay. So now I'm going to come to the last but not least set of relationships, and that's the doctor to community. So in thinking about this, what I'd like you to do is think about your community and who is your community. How do you define your community? And why might it be important for clinicians and researchers to build relationships with communities? The other thing that really became important to me as I continued along my journey was how could I become a global citizen to advocate for social justice? You know, because I grew up in Africa and I spent a couple of years in Europe before I came to the United States. And one of the things that I saw was that there are problems that we share no matter where we are in this world. And we are all connected. What happens in one place does affect people in other places, and probably even more so now than we were centuries ago because of all of the technology we have that keeps us connected and all of the ways in which we can travel and see one another. So it's been really important to me also to give back to where I came from. So who's my community? My community includes Baltimore, where I live. It includes the greater American society. It includes Africa. It includes people all over the world. And so that's why I think of myself as a global citizen. So I want to tell you about community-based participatory research, which is a type of research, and there are principles that include involving people from your community in all aspects of your research. We've done that. We've relied on the Baltimore community since we formed this center. And we did that before, but we formally did that when we formed the center. And this has really allowed us to bridge the traditional gaps that there exist between the community and academia, right? So there's been this history of not the best relationships between the community and Johns Hopkins Hospital because of a lot of things that went on, injustices, and it takes a while to build that trust and to build those relationships so that in doing the work we're doing, we know we're assuring that what we're doing is actually relevant to the people that we're studying and that we're using the methods that would be acceptable to them, right? So we have a community advisory board that includes patients, community members, providers, administrators, insurers. We have people from the health department. We have people who are leaders of different community organizations and people who are local business owners and faith community leaders. And they all are part of this board. And our board meets quarterly, but in between meetings, we also get input from members of the board for various aspects of the research as well as the training in the center. And then we also give back. So I'll tell you more about how we do that. But one of the things we had early on is we sat down and we planned together what our mission would be and what our goals are for the year. We do a lot of strategic planning. And then we decided, what principles do we want to guide our relationships? And these are the principles that we came up with: respect for diverse perspectives, partnership and decision-making, clear and ongoing regular communication, trustworthiness. So if we say we're going to do something, we do it, and we're transparent about, what our motives are, and then coming to some sort of concordance in our values. So really deciding what matters to all of us, why we're doing this work, and making sure that we represent that in our work. So we give back to the community. So, if they give to us, it's only right that we should give back to them. So we attend community forums where we help to educate the public about health and healthcare research and help to connect people with resources. And this is one example of one of those community forums. The other thing we've done is to advocate with health system leaders. So recently I was at a Johns Hopkins Medicine Board meeting, and I gave a talk on moving from health disparities to health equity, a vision for Johns Hopkins Medicine. For me, it's important to not just do research, but to actually relate to the people who can help to make change happen as a result of the research. So that's another relationship. Another way to advocate is to work with academic health centers, not just your own, but others. So this is a project we just completed, and I don't know, has anybody seen the videos from this yet? So if not, try to go to the AAMC website and see this. What we did was we collaborated with University of Maryland, Johns Hopkins, and the AAMC, the American Association of Medical Colleges, and the meeting was in Baltimore. So we interviewed people from the community in Baltimore. We interviewed about 20 people and asked them what they thought academic health centers should be doing with regard to their mission on regarding clinical care, training, and research to improve the health of the community and to achieve social justice. And it's amazing what they told us about what we could be doing better. So this is a great tool if you want to take a look at it. The other thing that we've done is to engage more with policymakers. So this is, I served in 2011, served on the Maryland Health Quality and Cost Council work group, and there was a work group that informed the policymakers about what they ought to put in legislation in order to reduce health disparities in Maryland. And so what our work contributed to was the passage of the Maryland Health Improvement and Disparities Reduction Act of 2012. And that legislation allowed for health enterprise zones to be formed in underserved communities with the aim of reducing health disparities. And what it did was provide funding to local health departments and to community groups to increase their services. And then also, it also provided incentives for physicians to practice in those areas by giving them tax credits or loan repayment assistance. So those are some of the ways you can partner with your policy makers. So the other thing that you can do is actually take your message to the public and improve your relationship with the public. And so I recently wrote this editorial in the New York Times because I was called and asked what I thought was a promise of precision medicine. And so I thought it was my opportunity to say I think there's a lot of promise in precision medicine, but also don't forget about how it could affect people of different communities differentially. And so to be mindful of that and to study not just the genetics and the biology, but to study all of the environmental factors and all the social and interpersonal factors that contribute to health. So, and then finally, this was my opportunity to advocate more with global partners. So recently, I told you about the Ebola epidemic that affected my home country of Liberia and also the neighboring countries. And what I was able to do was to get involved with the Data Safety and Monitoring Board for 2 clinical trials that were testing vaccines for Ebola in Liberia. And so I chaired the Data Safety and Monitoring Board for this trial that ran all of this year. And it was very interesting, very helpful to have people. There were people who were experts in Ebola virus and people who were infectious disease experts, people who are vaccine experts, and all kinds of scientific experts, but they needed people who actually understood the country, understood the culture, and understood what some of those issues the issues they might face in trying to introduce a vaccine for Ebola into that community. And I was grateful that I had the opportunity to be able to contribute that perspective. Even though I haven't lived there in a long time, I'm still connected to that community, and I do travel back and forth there. And there were a lot of people who don't live in Liberia who are Liberians who actually had a lot of influence on what happened or what didn't happen there. So happy to say that both of the vaccines are safe. And right now, the results are pending as to which one is most effective. So I'm getting close to wrapping up. I'm going to tell you a little bit about my own family. So my patients, my colleagues, and my community are my professional family, but I'm going to tell you about my personal family. My personal family, without them, I wouldn't be able to do any of the things I do. These are some family photos. I've already talked with you about my parents and my brother and my sister, but this is my son, Donovan, and my husband, Nigel. And you can imagine with having this goal of trying to save the world that you need people to keep you grounded, right? You need people to remind you that you need to come home and you need to get some sleep, and not only that, but don't take yourself too seriously. So they definitely helped me do that, and I'm really grateful to have them in my life. And they've actually helped to enrich my journey, just like all the other people that I mentioned to you, my patients, my colleagues, and my community partners. And so speaking of the journey, this is me at the Cooper Clinic. This is where it started. And this is when I went back most recently, where my parents began with their dream of delivering compassionate care to a community that was in need of it, regardless of race, class, or ability to pay, or any other social circumstance. So that's where it all began, but it continues. And I have to say that we still have many challenges before us. You know, like I said, health disparities affect us all. They're everyone's problem, not just a few groups in society. They're crippling our healthcare system, our economy, our health, our well-being, our political stability, our safety. And so what I'd like to do is to encourage you to think about what you can do, regardless of what your career path is or what your interests are. How can you help to move our society from disparities to equity? I'm going to leave you with a few parting thoughts for your journey. This is for the young folks in the room. Everybody here is young, I know, but. So first, what I would say is think about what your strengths and weaknesses are, and ask for feedback from people who know you and care about you. And I say this to my son all the time, and I said it to the medical students last night. Decide what matters most to you and do what you love. It's really important to do that because you have to live in alignment with your values. If you don't, you're not going to be at peace, and you probably won't be as effective as you could be. Develop a specific expertise or niche. So, find out what training you need to be an expert in whatever it is you need to be successful. That's important, and seek that out. Clarify your goals and revisit them regularly. If you don't do that, you could end up doing a lot of things. There are a lot of things out there to distract you and to keep you busy, but you might not end up being that focused, if you don't prioritize things, you're going to drive yourself crazy. So the other thing I would say is choose your mentors and your colleagues and your collaborators and your proteges carefully. And if you're not married yet, choose your spouse very carefully too. The people that you associate with are very important to your success and to your well-being and just to everything about the quality of your life. So think very carefully about those and work on your relationships. Make time for them. And then keep an open mind. Take chances, do something new, seek new experiences, keep growing. And then this is my final one, which is be a global citizen. Basically, care about the world around you, not just in your immediate community, but about the entire world. Think about things that make a difference to humanity. I draw a lot of inspiration from Martin Luther King and this quote where he said that really that all labor that uplifts humanity has dignity and importance, and it should be undertaken with painstaking excellence. So that means that's why we work so hard, is because it matters. There are people behind all those numbers and all that data. There are stories, and one day it could be somebody that you know very well. So make a career of humanity and commit yourself to this noble struggle. And my hope is that one day the children in Liberia, this is a sunset in Monrovia, that they and children from underserved communities all over the world will be able to have the good health and the ability to pursue their dreams that I have had. So I'm going to stop. Sure. Yeah, I was on the physical environment. I was actually talking about the built environment that people, so people live in. They may have poor housing. They could be exposed to lead. They could have sidewalks that are terrible and be, at risk for being run over by a car. So that's what I was talking about when I said the physical environment on that slide.
And that, therefore, as you matriculated through your career and looking back, how did you look at the built environment as a factor in the overall care process?
So that hasn't been a huge focus of my work. I have collaborators who actually work on physical environment issues. One of the ways that it's connected to some of the things I've done is that I've looked to see, for example, some of the clinics that I've done research in. What we've done is look at where the patients live that go to that clinic, and so we've been able to map out neighborhoods where people live, and then we can also get data from the state or from the city that maps out what the food availability is in those neighborhoods, like what kind of grocery stores they have there, whether there are, what the crime rates look like in those neighborhoods, so we can get a better idea of what the physical environment is that those patients are experiencing. And the idea is that if people who are delivering care can understand more about what their patients are dealing with, what you could do is go do home visits, as well. But another way of sort of capturing that on a clinic level is to actually look at that distribution. There's actually mapping that you can use in what we call geocoding, and that can help you better to tailor your services. That might tell you that your patients who come from that neighborhood need different kinds of nutritional support, or that they need they might need a transportation service to bring them because there's no bus line that goes from there, to the clinic. So those are just a few examples. Well, okay, so no easy questions around here. So. No, I think that you're right. We have a lot of things that we need to weigh. We have a lot of challenges that we face, and we have to decide how to best invest our resources. I think what helps is for us to be monitoring all of these situations on a regular basis and thinking really creatively about how programs to address one problem, they shouldn't be focused so specifically on that one problem that they cannot be applied to anything else. So I think that there are benefits to having tailored programs, but there's also a huge benefit in dealing with an approach that actually could be applied across a variety of different conditions or different populations. And one of the reasons I focus on relationships is because I think communication is one of those things. Communication and relationships affect every domain of care that you can think of. They affect the people's living conditions wherever they are. So, having better relationships and social networks helps whether you have AIDS or whether you have breast cancer or whether you have heart disease. So, I don't have the answer to your question, but I think that we have to continue to monitor those things. We have to try to measure the cost of the things we're doing. We have to look at how we can apply different intervention approaches across different settings. So I think one of the ways is to actually communicate about the success of those things and to tell those stories, so to get that out into the media or to get that to people, to decision makers, people who are in the position to make decisions about how to invest resources. So I think that's one of the ways. Another way is to have those groups partner with researchers that can help people actually measure how effective they are and evaluate their programs in a very sound way. So I think those are some of the ways we can prepare people so that they will have what they need in order to scale that program. Yeah. So, I think what facilitated it was, well, one thing. One thing that facilitated it is where we're located. We're right there in the middle of the community. So that's one thing I would say. There have been other things that have facilitated it, mostly relationships, to tell you the truth. It's mainly through talking with people who have actually had relationships with various people in the community and getting like recommendations for who's working on what and who might be interested in partnering and doing the work. Being willing to give back. I think it's hard for people that are junior to spend as much time doing that because we have a lot of other pressures to be productive clinically and doing our research, and we don't get rewarded a lot for doing that kind of work. But the reward is much more personal. I mean, I have to say at a point, I think you saw me that one presentation where I was talking at a community forum. That was at one of the lowest points in my career. I mean, I was kind of tired and frustrated, and I was having, rejections from journal articles, and my grants weren't getting funded, and I went to that community forum to talk, and when I left, I felt so uplifted and enriched and happy, and I thought, if only more people like actually understood or experienced this. So I think doing that and doing it with bringing other people along with me also facilitated doing it, because I don't think it's something that one person can do. So we share it. So having a team of people that are willing to do it, building relationships, I think, I don't think the institution itself didn't have a huge focus on, doing this, especially for somebody who's doing research. It's maybe viewed as not hard science and that kind of thing. But I think as they've seen the problems going on in the city, they've come to realize the importance of having that good relationship with community. So I think in a sort of weird way, the negative things that happened in the community this year in Baltimore have actually facilitated some of that, community connection. And I think the School of Public Health has had much more of a community-oriented outreach approach than the School of Medicine. So I think also having them, and the School of Nursing has also, facilitated that a lot.
I admire a lot of things that you've done in terms of the political work you've done. The health empowerment zone idea is very, very creative. How do you get physicians who are generally not as politically active and engaged involved around trying to build ideas to help legislators improve healthcare?
Yeah, so I think a lot of it is, I think if you help people see that, it's a learning experience for them, So for me, actually going to that council and listening to all the different viewpoints and learning about what other people were doing, like in other sectors, like, I don't know, housing and the child foster care program and all of this, it really got me thinking about patients that I see and things that would help them. And I think if people can see that it's not, that they actually have a role to play in that whole process, because they're counting on us to bring our expertise to the table as well. Like, people in those other sectors of society know what they do, but they don't really always understand from a health standpoint how what they're doing could affect a person's health. And so it's really up to us to kind of educate people on that and to bring that perspective and to advocate for the health of our patients and our community. So if you can help people think about that, I think most of us go into medicine because we do want to help patients and we do want to make a difference in society. And so even if it's not the most glamorous thing, it's still something that's really educational. And I think that in and of itself, you don't have to be an expert on law or policy to do it. You can just bring your own expertise. Wow. Okay, so I'll start with the successes. Now, I think the successes are that, like, a lot of people now understand that, that when they go in for care, that they have certain rights and that that they can expect to be asked, their opinion about different treatments, and that, when they sign a consent form, it's really up to them to decide whether they are going to, do something or not. So I think the public is much more aware of that, of their role and their right. And I think with the Affordable Care Act, there's been a lot more kind of focus on that, on, people advocating for what they need and, pushing for being able to have health insurance and access and all of that. So I think we've made quite a bit of progress with regard to that. I think where we haven't made as much progress is, and then we have health information technology now where people can actually, go into, they can communicate with their doctors and they can review their medical records and things like that. I think that's great, and they can even do that on their cell phones. So a lot of access to like health information and kind of empowerment of our society. Not everyone can benefit from that equally, so there's always the problem of people who get left behind with that, and I think that's an ongoing challenge. I think the other ongoing challenge is that, and I don't want to minimize that because I think that is one of the major challenges, is that not everybody is prepared to be an active and informed patient, and so we really need to work on that. The other piece, though, is to help support clinicians in being able to deliver that patient-centered care, and I don't think culturally we have done enough in our profession and in our organizations to foster that. There are some examples of great work where that's going on. I mean, I know Kaiser is doing a phenomenal job with that. I was trying to think if there was another, there are probably like a few places that really have a strong focus on building that culture and supporting clinicians in that, in being sort of more patient-centered and more humanistic. But I think we have a long way to go with that. So I don't think it's either or. I think it's both. I think we do want to look within groups for within group differences, but I think we're also still concerned about the between group differences. I think, what I would say is that the shift in thinking about it is less about what's wrong with a group that's not doing well and more the focus of like, what are we aiming for and what do we need to do to get there? Now, if we find that there's some people that are already achieving that within a certain group, it's also focusing on what are the strengths and what are the positive factors that made that possible and actually trying to build on that, as opposed to thinking about it as a deficit. Thinking about looking for assets and building on assets and using strengths of like the people themselves and the communities themselves.
Yes, please. At the risk of hanging out of work, do you all get together at all and discuss this?
Well, we do, and we don't do it as much as we should, but there is a concerted effort now for us to do that, and I've been really pushing for that because of the very reason you stated. We need to have a cohesive story, and we need to have a coordinated plan for how we deal with the community. Otherwise, we send mixed messages. We overstudy and overburden certain groups of people, or certain groups of people are completely left out. So we So I think we're working on it. I know you have a focus on diversity and inclusion here in a specific office, but also a plan that involves other people within the organization. We have that. We have a vice president of the health system that is a vice president for diversity and inclusion. They're going to be also naming a vice president for health equity shortly. So there's going to be a lot more coordination of efforts. I think it's improving. I don't know if it's completely better. I'm sure there's still pockets of negative, bad blood, for lack of a better word, but I know the community has been extremely supportive of me and my colleagues anyway. In fact, during this last dry spell of grant funding, they were just like, do you want us to write a letter to the dean? They need to give you guys money so you can keep doing this work, so I think it's improving.
But there won't be in the Dow chair named for Freddie Gray quite yet.
Not yet, it doesn't, but as soon as it is, I'll let you know.
I want to thank Dr. Cooper. Last evening, she did a wonderful seminar for Bucksbaum students and fellows, then had a meeting with just our medical students, and then this public lecture today. It's been a delight to host you, and I look forward to your quick return to the University of Chicago.
Thank you.
Thank you.